Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
So Sarah and I always love to talk about nutrition. Yay! It's one of our favorite topics. And so we're talking about it again today, but in a different way. Food is really one of our most powerful tools that we have to influence our health. But it's really often overlooked as part of our actual healthcare system. So today we're diving into a growing movement that's happening in the food as medicine world. And you might be hearing that more and more in the news or in the media. And we're excited to have an expert in this. We're going to be joined today by Alison Gustafson, who is head of the Food as Health program at the University of Kentucky, which is really an initiative trying to integrate nutrition directly into the medical care through things like medically tailored meals, grocery prescriptions, meal kits, trying to see how this makes a difference in chronic disease.
Just really trying to help bridge that gap between what we know about nutrition and what actually gets implemented in the real life to patients, because we can always tell patients about things, but it's really nice to see patients be able to receive food that they're supposed to eat and implement that into their lifestyle. So in this conversation, we're going to explore what food as medicine really means, the evidence behind it, and how these programs are actually being used to support patients with conditions like diabetes, pregnancy-related health concerns, HIV, and we're also going to talk about challenges that patients still face even when they're in these programs and what it might look like for these programs to actually become the standard of care in healthcare and what we need to do to get there. So I'm excited to dive right in. This is very exciting for me to have this conversation. So let's get started by just letting our guests explain how she got here.
Sure, I'd love to. So I'm Alison Gustafson, and it's nice to be here. Thank you for including me today on this. So how did we get started? This movement is definitely not mine. I cannot own it. Food as medicine has been a movement for the past couple of years. Some of my mentors in that space have been Seth Berkowitz at UNC Chapel Hill, Dr. Kevin Volpe at Penn. So lots of different folks have been in that space. In Kentucky, at least, what we really saw is learning from other states about what was working in their states and what wasn't, and then how that can work in Kentucky. Because even though as a nation there's a movement around food as medicine, what works in California or Massachusetts, right, we're laughing, is probably not going to work in Kentucky.
Yeah,
and
right.
so that's okay. So it's just different. So once we saw that there was a policy change about screening for food insecurity, I really started to say, what are we going to do with those individuals once you've identified that they're food insecure? There is definitely a lot of great national, federal programs to address food insecurity. When people hear that, typically you think WIC, Women, Infant, and Children, or SNAP, Supplemental Nutrition Assistance Program, or like Meals on Wheels, right? And so there is a lot already out there. But the difference really that we start to notice in food as medicine is that's hunger relief. So when we think of food pantries, or we think the design of SNAP was hunger, that was the point, okay? It wasn't nutrition security. That even wasn't a term when SNAP started. And so those programs fill a need for immediate calories. They don't necessarily fill the gap for healthy nutritional calories. And that's not to say SNAP can't do that, but that wasn't its target. That wasn't its purpose. It was to say, here is a wide variety of foods that you can purchase so that we can target hunger. whereas food as medicine is really at the top of the pyramid. So it's tailored components of food to address diabetes, to address heart disease. And those two can be married. So you can address food insecurity while also addressing nutrition security so that it's healthy. So that's one group of people. And another group of people has nothing to do with food security. It's that they have diet-sensitive chronic disease, and they don't have the skills to date to purchase and then prepare those healthy foods that are best for their diet-sensitive chronic disease. And so that's another group. So they may not have food insecurity, but they have limited income, and they also have a limited skill set, which is okay. We all have limited skills. I don't know how to do AI. We all have limited skills. And so this food as medicine can help fill that gap where that skill set is, and then show people this is what your diet plan should look like to address your disease. So the reason that I started to look at those gaps and say, what in Kentucky can we do? So that's where it started. That was the origin story. A, some policy change around screening for food insecurity at hospitals and other social determinants of health. And then B, learning from other states. What are the gaps in this system, in this food as medicine system? And how can we do it differently, meeting our patient needs, but also just the needs of our state? Because it's different. It's a different state. So that's really where it started. And I first just started upstream and started to understand screening.
Yeah.
And that's all I started on. And so I know a lot of times people love to dive into the food part. And I always say, food's going to be there. I'm not worried. Like, food's there. That's good. What's really difficult? Working in healthcare systems. It's really hard. It's really hard. And so we think of the whole food as medicine system, it starts with that healthcare provider or your health insurance provider, screening and identifying the patient. And so that really was the first step in helping to develop this entire network or system approach.
I'm curious, I think it's a little bit easier to tease out the financial food insecurity versus someone that just doesn't have the knowledge and know how to handle the diet-related chronic disease.
Yeah. So this is hence where we started with screening. So we said, let's just start, how do we work with healthcare organizations so that they're screening for food insecurity? Because just because it's a mandate doesn't necessarily mean they do it, right?
No.
Yeah. And that's not a critique to anyone. That's just what it is. And so also healthcare providers are overwhelmed. They're burdened, especially after COVID. People are just very tapped out. And so we wanted to make screening as easy as possible. We learned that the both and is the way to go. So you can screen for individuals automated, like they can get a text message. They could do it when they check in, or screen face-to-face. And just depending if you're rural or urban, it just depends on what you prefer.
Interesting. So what was that?
Yeah. So urban, you won't be surprised. Automated is fine. And then rural, you need to do face-to-face because they need to have trust. And they don't necessarily trust that automated version. So that we learned right away was really important for that screening, that first step. And then what we learned is, so here's an example that I give in many presentations. So at UK Healthcare, for example, we had about 10,000 people were screened. Around 600 said, yes, I have food insecurity. We know that's actually a really low. It's super low. There's no way it was that low. But that shows you that people don't want to be honest about that because there's shame or embarrassment or whatever that may be. Of those around 600 that said, yes, I'm food insecure and had a diet-sensitive chronic disease, only about 200 said, yes, you can refer me to a free food as medicine program.
Wow.
Yeah. So why did 400 people say no, thank you?
Yeah. Did you contact him and ask?
Oh, yeah, for sure we did. And so some of the biggest reasons were embarrassment, shame. They didn't understand the program was free. They didn't understand that the program wouldn't remove other benefits from them. But the biggest drivers were shame and embarrassment. So that's where our healthcare providers can do an amazing job about connecting and saying, you deserve this. This is a right. You deserve this program. And yes, it's free. Yes, it doesn't impact your benefits, but that it's something that is not a handout. It's a hand up, and it's to help you manage your disease. It isn't necessarily focused on the food security part. It's a tool to help you manage your disease. So that's where healthcare providers can do a really amazing job at helping navigate that higher, we call it the referral rate. Okay, so Of those that are eligible, how many were referred? We call that the referral rate. So we're really working on that. And a success story with just the referral rate is this. So we are working with Bluegrass Care Clinic, and their patients are people living with AIDS and HIV. And so that referral rate, right? Remember, we had like the 600 and then the 200 came. Their referral rate, when so far we've had 77% referral rate. And it's because their social workers, their nurse case managers, typically it's been social workers, but their nurse case managers turn to them and say, here's a free program to help you manage your disease. It isn't about addressing the food insecurity. And so we've seen a much better referral rate among that clinic site.
Yeah.
So that's a key piece. And so again, when people say, we're going to do food as medicine and it's going to help all these people, I'm like, you have to get them in the door, right?
Yeah.
You have to get people in the door. And if they're feeling shamed or embarrassed or they don't understand the program, they're not even going to walk through the door. So you could have the most beautiful lettuce ever, but no one's going to eat it because you can't get them through that pathway, if that makes sense.
Yeah.
This is just so fascinating to me because if thinking about, and I think we've done such a bad job in healthcare. And I think that's part of this problem is for so long we haven't looked at food as medicine, a prescription, because there are times that maybe a patient would never even think twice if they were told that you had to prescribe them Ensure or that you had to put them on tube feeds. That would never be an issue because that's seen as a medical need. But we have not created an environment where we see food as a medical need. And that really just makes people feel like they're just going to a food bank and receiving a handout instead of medical care.
Exactly. And so it's the same with a med. If you said to the person, oh, you're not doing well on the med for cholesterol. You're not doing well on that statin. We're going to move either your dose up or we're going to change what statin you're on. No one would blink an eye. They'd be like, okay, sounds good. Thank you. So that's how we want to start to look at that food process for referral to say, oh, your blood pressure is a little high. You're already on this med for it. This prescription for food would help manage that as well. So it's just changing that conversation. It's changing how we look at it.
Now, is that something that you all had to... Did you write scripts for people to use on the perfect thing to say, or was it just more education? Like, how did you achieve such a high change in percentage?
Yeah, because we have learned so much for 3 years. So everything I just boiled down was 3 years of testing this. So we partnered with UK Healthcare, U of L, and then Appalachian Regional Healthcare. So we partnered with 3 pretty large healthcare systems to understand, like, what are the pain points? Where are the gaps? And so that was 3 years of learning what was not working and what was working so that we would fine-tune our messaging. We fine-tune their scripts and their messaging for referral and enrollment.
That's great.
Yeah. So it did not happen overnight. It was 3 years of work.
And I think as Sarah and I talk about this multiple times on the show, but a lot of physicians don't think of food as medicine. And so they may not be thinking about it for heart disease patients. They're thinking about, are they on their ACE inhibitor and their beta blocker and statin? And maybe they mention sodium, hey, try to cut down your salt, but they may not think about enrolling someone in something like this.
Yeah, I don't know that we're worried about the frontline doctor. We want to have the front line with the nurse or the nurse case manager or the social worker or who will say, I'm going to now refer you because they're overtaxed. And so one thing we've learned, even just now we're in conversations with Baptist Health, we're in conversations with Owensboro Health about doing some smaller projects with them. When I tell the healthcare provider, I say, we relieve all your pain points. The only thing you have to do is identify the person. They say, I'm in. But if we turn to them and say, I need you to identify the person and I need you to help them fill out a form, and I need you to hand them a script, and I need you to do this, they're out.
Yeah.
So we really do, that's why we started this hub model, is because we saw from other states, when you rely too much on the healthcare system to do something else, they don't. And it's not that they don't want to,
right.
Oh, yeah.
We've been there. There's already so many things.
They're so burdened. And we just want to make sure in our model for our state that we are not putting anything more on our healthcare providers. The only thing that we're really asking, if you will, is that those nurses, nurse case managers, it could even be the person when they're checking out. all they need is like a check mark that says this person is eligible. And when you're going to say who's eligible, that's what kind of, when we say the client, gets a little tricky in that each program decides who they want to serve because you can't serve everyone. So if we could, we would serve all type 2 diabetes, all high blood pressure, all high risk pregnancy. But you can't. So that's where there is no one size fits all because each organization may say, we're going to really focus on this group of people. Do you see what I'm saying?
Got it.
So
Yeah.
that's how they then identify who's eligible is.
That makes sense.
Yeah. And so here's an example. In California, they do hemoglobin A1C over 9. So I'm just giving that as an example.
Yeah.
Do you see what I'm saying? Whereas some of our other clients just say, oh, any type 2 diabetes. So I think it just depends as far as, the burden on the healthcare provider. It's just to say this is who's eligible and here's the name.
Let's dive in. Can you tell us about a program that's been going for a while that has had results, and what kind of results have you seen?
Yeah, sure. So again, we've partnered with UK, Appalachian Regional Healthcare, ARH, and then U of L Health, and then UK Healthcare. So we've partnered with them, and we've served over about 600 Medicaid adults, type 2 diabetes, and high blood pressure. And they're all received at that point 3 months of a program. So it's nutrition counseling, and then we call it engagement check-ins. So these are just phone calls that our referral coordinators do that say, how's the program going? Are you eating the food? Any questions? And it really is, we call it high patient touch. I know in the world of tech, you're like, can't you just do that automated with a chat bot? People don't like that. People want you to pick up and answer the phone if they have a question, if they lost their card or whatever it may be. So we do high patient touch, which we has shown really high engagement. So of the people that participate, 95% complete all 3 months.
Wow. Wow, that's huge in research,
huge.
everybody.
Yeah, that's really great. They do not drop out. And we find that because we offer that high patient touch, high check-in. So the reason I bring that up is, 95% complete. It's been type 2 diabetes, and then pregnant moms, and then hypertension. So we've seen a reduction of about 8 milligrams of systolic blood pressure, 4 diastolic blood pressure, and then about a 0.5 hemoglobin A1C, depending on the program. So we're really seeing clinical improvements.
That's a medication.
A medicine.
Yeah.
Yeah. And what we are really now hoping to move forward a little bit granular in the future is maybe folks who have blood pressure unmet or poorly controlled, like 140 over 90, do they need 6 months versus someone who's 130 only needs 3 months?
So just to
some of that needs to be teased out.
I want to clarify that. You were seeing those results just after 3 months of this.
Yes.
Now, did you all continue to follow after those 3 months, or what happens if someone's in a 3-month program?
Yep. And so that's what I was saying. So now we're seeing kind of the 6 month and 12 month
got it.
Outcomes. And so that 6 month, they go up, their blood pressure goes back up, but very minimal, not significant. Can't speak a year later. I can't say you that a year later. But 6 months out, they're good, pretty much the same. And one of the biggest reasons also is we do a roll-off program in that most of our participants were on SNAP. Our program helps them understand how to utilize their SNAP benefit.
Oh.
So to mimic. So when they've been receiving the Food as Medicine program, now they understand what to be purchasing or what their portion sizes should look like, what the salt level should be. They really understand, so they know how to utilize their SNAP benefit in a more healthful manner.
That's great. Yeah. And in regards to that specifically, did you see a difference between the different populations, like urban versus rural?
Yeah. So actually, urban did a little bit better. And people think, oh, they're rural, they're going to garden. But that's really not what goes on. And so we did see urban was slightly better outcomes than our rural. But now what's interesting, rural medically tailored meals did not do very well, versus our urban medically tailored meals had really strong clinical outcomes. The grocery people, the people that got a healthy debit card that you can only purchase healthy food on, that matched their diet-sensitive chronic disease. So it matched sodium guidelines for hypertension, or it matched carb counting for diabetes. They did the exact same. And the reason I think that's really important is that people like choice. And so a grocery prescription or a produce prescription, it offers people choice. They can choose the healthy foods. Versus medically tailored meals, you're stuck. Like, this is what you are going to consume. Now, for a certain group of people, those who don't have a kitchen, those who don't know how to cook, can't cook, like they don't have any utensils to prepare food. Transportation is really difficult. I think medically tailored meals serve a very important need for a small group of people. So I don't think we should, again, take it off the plate, but we want to be thoughtful, again, about who that prescription is for. And I bring it back, again, to medication. With medication, you don't give everyone the exact same med and the same dose. As doctors, you don't do that. So why would we do that with food?
Yeah.
Why would we say everyone just gets medically tailored meals, or everyone gets a grocery prescription card, or everyone just gets a produce prescription box of fruits and vegetables to the door? What if they don't know how to cook? What if they don't like it? So I think, again, we offer that suite of options. And so I'm going to come full circle to our screening decision tool, matching people's needs, preferences, where they live, to which food is medicine package they receive. Because everyone has different needs and different preferences. And so we need to match those needs and preferences with their food package.
Now, when you had mentioned that you all do nutrition counseling, are you teaching people how to cook?
Yeah, so it depends on the person. So if they have a working kitchen, if they say, yes, I want to cook, then yes, that registered dietitian will go over cooking skills, how to prepare. And then we also have a host of videos that we send to them. Like sometimes one of the most favorite ones was like how to cut up a cauliflower head. Because it can be daunting. You're like, here's this big white bulb. What do I do with it? So just showing basic knife skills, how to cut that cauliflower up, has been one of our biggest video hits.
Do you have one for pomegranates?
Oh my God. Have you seen those where like they knock on it and then they come out? I'm like, I don't know how to do that. Yeah.
I tried it at Thanksgiving. Yeah,
Did it work?
It works, yeah. Uh-huh.
How hard do you knock? Like,
Pretty hard, yeah.
Oh, okay.
Since this has like a finite end to it,
Yes.
has there been any comparison? I would think the patients that are learning to cook and getting the grocery prescription or the produce prescription have better outcomes long term than someone that's getting a medically tailored meal and then stopping. Or has that been looked at?
Yeah, we're not there. Yes, and trust me, researchers all along are like, okay, we want this data, we want this data. It's just this, even though food is medicine topic has been around, it really is like a newer space in the research. And so no, we don't have 1 year out, 2 year out data on that.
So not just you, across the board.
Like across the board. Do you see what I'm saying?
Yeah.
And then what's been tricky is some of the states that have done, in the policy world, these are called 1115 Medicaid waivers. Massachusetts has one. North Carolina had one. In California, they call it in lieu of service. These are different mechanisms that you can then have your state government pay for these food as medicine programs. Well, California is like just now finishing year one of their HOP. Do you see what I mean? And then then they're going to have to follow those folks that got the medically tailored meals, and then a year from now. So
yeah,
it's
still
take
coming.
A while. And then Massachusetts, a great group is called Community Servings, and they do medically tailored meals. Just a phenomenal group. I haven't seen that they followed. So like maybe next week they'll be publishing, but it's been really just more like this 1 year out hospitalization. Do you see what I mean? And it wasn't specifically medically tailored meals. It was just the program as a whole, if that makes sense.
Yes.
Yeah.
It's just so new.
I know. It's so exciting, though.
The other thing I'm impressed by is how many people stay in it. What is like some of the verbal feedback that you've gotten from patients? Or I'm just super impressed that many stuck with it.
Yeah. So a lot of it is that they feel supported. More than support, like it's maybe not a friend, but someone that there's trust. They know that this program is looking out for their best interest. That we're not trying to get something from them. It's not an exchange or a buyer relationship where you're paying for this and now I owe you this. So there's just that. We're just here to help. We think this food program can help you manage your disease. We are looking for an improvement in clinical outcomes. That is, we're very honest about that in the beginning when they're enrolled. That's what we're going for. That's what we want. And then I'd say, really, I'm not going to take any credit. So it's our referral coordinators and our program manager has thought of every little hiccup that can happen so that it's a seamless experience for our users. And then our referral coordinators are amazing. And they're from Kentucky. They're from communities where our members are from. And I think that's really important. And sometimes, and there's nothing wrong with a bigger organization, but a lot of times these like remote companies, they'll be on the phone with a registered dietitian that lives in New York, and they're in Hazard. It's hard to identify with the RD that lives in New York City when you are sitting in Hazard and the nutrition counseling.
Totally believe in that.
Yeah. So I think it helps that our staff, in a sense, are locally based and understand the communities.
Now, what obstacles or negative feedback has been about it?
Yeah, sure. So one, definitely, and this is one thing, I say it on all these podcasts, all these things, I'm like, we need a local medically tailored meal provider. So one thing is we love our national provider. They're great. They can get into every nook and cranny of Kentucky, which is great. And from a research perspective, it's nice that you have a standardized meal so you know everyone's getting the same meal. Do you see what I mean? So then you can compare. Okay. However, we have partnered with Dare to Care, and their medically tailored meals were fantastic. And then we have partnered with Food Chain, and their medically tailored meals were fantastic. However, it's an and, because what happens is in those smaller vendors that we work with, they can only go in like a 20-mile radius. They can't go much farther than that. So we want to work with our community groups, and we still need a national partner. So the complaint typically with the medically tailored meals, there's always someone who, I didn't like that flavoring, or that I didn't like rosemary, or I didn't, because you can't meet all taste buds with those. So that typically is the complaint we get with medically tailored meals. In a perfect world, we'd have 8 different medically tailored meal providers in Kentucky, and then you could pick what you wanted. I don't think we're there yet. I don't know that anyone is there yet. But anyway, that's one complaint. And then I'd say there's really never a complaint with the grocery prescription card. It's really easy. We make it user-friendly. We have a 12-hour text line, so if you're in the middle of shopping and you don't understand something, you just pick up the phone and call, and then our referral coordinators help you walk through what you can buy, what you can't buy. They don't really have issues with that. And then our other vendor is Instacart Fresh Funds program, and the only time we've had an issue with Instacart is people just don't always understand like how to set up their cart or how to do that. And even though we've walked them through it, someone who's not tech savvy, it can be a little daunting. But typically, again, we don't allocate those people to Instacart. Someone who doesn't understand tech, then we just say, oh, Instacart's not for you. We're going to send you the debit card.
Yeah. No, that makes sense.
Yeah.
Now, in some of this work, what ways have you tried to engage communities in general, like outside of healthcare, to this program?
Yeah, so we're working hard on that. This is now like the other side, like the food side, supply chain, and then legal. Whew. So one thing we are, again, like Food Chain has been a great community organization. We've worked with them. They refined their medically tailored meals to meet dietary guidelines for American Heart Association or American Diabetes Association. Dare to Care has been fantastic, and they offer other programs that we're not part of, which is great. Another group that we're not part of, but we like to shout out, is Cane's Kitchen up in Eastern Kentucky. They're doing medically tailored meals with Mountain Comprehensive Cancer Center, and they're doing a fantastic job with their meals. But again, their model, and it's good. It's not bad. It's just they're having community health workers go to Cane's Kitchen, pick up the meals, and then deliver them to people's doors. So when we think of scale, that isn't a scalable approach. Nothing wrong with that approach. It's great. And if it can meet those 100 people with diabetes and they're happy and they feel connected, how wonderful is that? You know what I mean? That's fantastic. But our model of the hub model is that when we have members from insurance that live anywhere, we have to be able to serve them anywhere they live. And so it's a both. So you have to have different partners for different reasons. And then the other group that's doing a great job is Feeding America Kentucky Heartland. They have a small grant, and they're working with Need More Acres Farm to do once a month a produce box. There's different models. There's different ways to go about that. We would love, one of our perfect models is actually working with UK King's Daughter. So UK Healthcare bought King's Daughter. So we're now working with UK King's Daughter in this model, and we really like this for our state. So the person is type 2 diabetes, hemoglobin A1C over 8, and they get $60 per month in a grocery prescription card. And then if they spend it all, they spend all $60 and 25% of it is spent on fruits and vegetables, they get a $40 voucher to be spent at their farmer's market.
Wow.
Oh, I love that.
Isn't
wow.
that?
I like that.
Me too. Yeah. We love this model. We'd love to see, and this can be scalable, right? Because you can do the grocery, and then if your farmer's market isn't close or it's not in season, you would just get an additional on your grocery. But if you do have a farmer's market, it's in season, it's open, then you would get that $40 to be spent at the farmer's market. So we just think that model is really scalable. And the extension agent in that county, in that area, then she leads classes in addition to our nutrition counseling. So they get the one-to-one nutrition counseling, plus then they get this cooperative extension programming, dining with diabetes. So it's this full wraparound service program. So that when we say community partners, plus industry, plus healthcare, it is the perfect model of what we'd love to see everywhere in the state.
Yeah, because I was trying to think when you were talking about how to bring the community in, and I'm thinking about where do people shop. It's usually Walmart grocery stores, Kroger grocery stores. A lot of people, Dollar General is what's closest to them. Is there any type of feedback from them that they are willing to participate in these things and try to have healthier options more obvious to people?
Oh, changing the food environment within the store. Yeah, so that is my previous research. And I will say there's probably 500 researchers over in the course of the 2000s that we tried to do that. We clearly were not very successful. I don't know that's going to shift. Those are big corporations who have a bottom line. They have money to make. And so the onus is really on the customer to make that healthier choice. We work with Kroger, Food City. We work with all those grocery partners. And I think especially Kroger Health is at the table with Food as Medicine. Food City is at the table. They want people to be buying healthier. But at the end of the day, it is a corporation. It's a business. They have to make money. So I don't know that changing the food layout or offering like reduction in pricing or I don't know that's going to happen.
You've talked about some of the programs you currently have. Are there new ones that haven't started yet or that are coming?
Yeah, so we have a new one starting with Golisano Children's Hospital, UK Healthcare, so kids with cancer who are undergoing treatment. So they'll be getting a grocery prescription program. So we'll be starting that this summer with them, and we're really excited to branch into cancer. So that is definitely an area. And again, payers have to decide. There's not a lot of traction on the payer side. There's a lot of traction on the payer side for diabetes and high-risk pregnancy, a lot of traction. So we have 3 contracts, one with UHC, one with Passport by Molina, and then a third is with Aetna. And their focus is type 2 diabetes and high-risk pregnancy. And again, there's only so many dollars, right? And so you have to pick. So we're just so excited they wanted to partner and offer this service to those members. But there has not been a lot of focus on cancer. And so we've reached out to Markey Cancer Center and Golisano Children's Hospital, and they're open to us doing this with kids who right now are in treatment for cancer.
And what is the focus of those meals for those patients?
Definitely more a balanced calorie, heavy focus on healthy fat, protein, and carbs, more of a balanced, health while you're in the middle of treatment.
That's fascinating because I hadn't heard of any programs focusing on cancer, so that's exciting. That's happening.
Yeah, we're excited. Yeah. So hopefully that can grow. And I know American Cancer Society is obviously passionate about this space as well.
And does any of this end up going back and helping our local agriculture and our farmers? Like if we're giving cards to go to the farmer's market, do we see that's actually benefiting?
Yeah, glad you brought that up. So Food Chain, as I mentioned earlier, so we did a project with Food Chain and it was medically tailored meals. I don't remember the exact percentage of the food was all local food. And we had a ag economist, Blueprint Kentucky, which is a group within UK Healthcare, does this analysis. They do farm impact analysis. And so they estimated, so we had 50 people did it, but they said if X number had done it, there would have been $10,000 revenue to farmers that participated just in a 3-month medically tailored meal program.
That's significant.
10,000 revenue. Yeah. So that's where Kentucky Department of Ag is obviously leading a Food as Medicine. They're really focused right now on getting local food into hospitals and into schools, which is great. But this is the kind of work that we want to do to help inform our legislators that Food as Medicine not only benefits the patient, it can benefit the farmer.
Yeah.
It's all about money. So what happens is that meal, the rate at what is reimbursed if you have local food needs to be higher to then help the farmer.
Yeah.
So if you say to Food Chain, I'm only going to reimburse you $7 for that meal, right? Then Food Chain would take a loss on that meal because she's buying it local and she's paying a premium for that local food.
Yeah, that's tough.
Do you see? Does that make sense? So this is where Kentucky legislators and Kentucky Department of Ag, they can play a role and say, if food chain's willing to do medically tailored meals, we would reimburse at a higher rate for that meal because it's local.
Are there any options for patients, let's say, that are screened and they have a diet-sensitive chronic disease like diabetes, but they have a higher income? Can they pay to get the same thing?
Yeah, we're working on that model now. We're definitely working on that. One thing we're interested in offering to people would be like a free Instacart membership, or we can send them like the debit card, and then they can just pay for like the nutrition counseling, or they can pay for the text messaging tips and videos and that. So we're working on what that model would look like.
What other things are coming out from different payers? Are more payers getting on board of coming up with different forms of reimbursement? What does that world look like?
Oh, that is a messy world. Right now, we're very excited that we have these 3 contracts that they're paying for this program, this service. What we do know is that our insurance providers are all at the table. So we've all done pilot work with all 5 Medicaid providers. Anthem on the Medicare side is at the table for food as medicine. Everyone is very passionate and committed to it. What does that look like for each payer is probably going to be a little different. One thing that we are anxious to see in the next couple of years is this in lieu of service. And so that is a policy mechanism that our state can do. And what that means is when the contracts go up for Medicaid providers, for insurance, then they will have, in a sense, a line item that says like food and nutrition supports, or it won't really say food and medicine. It'll just say like food and nutrition supports. And so it's literally in lieu of something else, then they can offer this food as medicine program, and then the state would cover that. So our insurance providers are all passionate about in lieu of service happening. I think because we have a little bit of wiggle room until 2028, I think we're waiting to see just what is the political landscape in 2028 look like.
No, that makes sense. And also I know that there is a lot of people applying for MAHA Elevate, which is looking specifically at food as medicine. Can you explain to our listeners what that is and what some of the research going there looks like?
Yeah, sure. Make America Healthy Again. Elevate is a large grant that has been released, and it's due May 15th, just right around the corner. It's really big. So one thing around MAHA Elevate and this is a very small segment of your audience, I'm sure, cares. Food is actually not covered in MAHA Elevate. So people are thinking it's food as medicine. Food is not an allowable expense in that grant at all. So what is allowable is lifestyle medicine and functional medicine, right? So counseling, anything, but there must be a nutrition aspect or a physical activity aspect. So we are fortunate in that I am a current recipient of American Heart Association money. And so we are in strong conversations that American Heart will cover the cost of food for our grant application. So we will be submitting a lifestyle medicine with food support grant with 5 healthcare organizations across the state. So our application covers about 2/3 of the state.
That's impressive.
Yeah, that's exciting.
Yeah.
And that, again, is just trying to make this a part of everyday healthcare and to get it covered.
So Medicare, and this is original Medicare, so MAHA Elevate is only focused on fee-for-service or original Medicare patients. There is no reimbursement for high blood pressure counseling. So if you're type 2 diabetes, you actually can get a little bit of counseling reimbursed, but for high blood pressure, you cannot. So that's our model. That's what we're looking at, so that we can help inform CMS or Centers for Medicare and Medicaid about, for those with really poorly controlled high blood pressure, nutrition counseling, and then stress management, alcohol reduction, and then food supports.
Yeah, that was one that I felt like I learned a lot in lifestyle medicine of the significant impact that it can have on high blood pressure, which I did not counsel enough on as a physician.
Yeah, I think salt was like the only thing I ever
we talked about.
Really mentioned. So do you think if with these pilot programs that are happening right now that we see success, do you think that this would be something that we'd start to see with commercial insurance and kind of just standard of care at some point?
Yeah, I think absolutely I do. I think it's only going to be for a very small group of at-risk people. And here's why. So Medicare Advantage plans, if you've ever seen those commercials, they offer a healthy grocery benefit card. Like they offer it. Like, have you ever seen like the Humana commercial and they're like, you can get $50 grocery, or like Aetna Medicare Advantage, like you can get. So like they offer a grocery benefit card. Some of the plans already offer a Fresh RX produce box sent to the participants' homes. Many of our Medicaid contracts or plans in the state offer 2 weeks of medically tailored meals post-discharge for type 2 diabetes or pregnancy. So they've been doing, like, it's there. I think what's not there is it's for 3 months. Do you know what I mean? It's for longer. And it's very focused on a specific disease state, plus nutrition counseling, plus stress management counseling. So I think that's where we need to be really deliberate in not throwing everything in the kitchen sink, because then it's not clear what should be covered and what shouldn't, if that makes sense. Mm-hmm. And then if you're insurance, you're just like, I'm not doing anything. But if we can be really focused at, this is the group that needs to be covered, this is how long they need to be covered, and then which programs need to be covered, I think we have that. I think can happen. But I think we have to all be really deliberate about how we get there.
Yeah, and that's hard. Sometimes we always want to just throw everything but the kitchen sink at something. Yeah. So having some restraint there probably would be helpful.
Yeah, and so like here again, like our community groups where it's, oh, we want produce boxes. What if you're wrong? And I say that to people, I'm like, what if you're wrong and like a produce box just isn't a great way to go? It might be a good way to go for the farmer, but it might not be a great way to go for clinical outcomes or like medically tailored meals. What if it's only good for 5% of people? We don't want to just make everyone be on those. And so I think we just have to be super thoughtful about what does the evidence say, and then say, okay, these are the groups that we're targeting, and this is how we're going to target them.
And for the average person that, let's say, is maybe overweight, maybe their blood pressure is starting to creep up or their blood sugar is creeping up, but they don't really have these chronic conditions yet. And we know these are people that need to make changes now, or they're going to end up in these high-risk populations. Is there any movement within the Food as Medicine to target that group of people?
One article that just came out, I'm going to say his last name, but it's like Jurassic, but it's Harvard, it's just in Nature, and it was Dash Groceries. And it was for blood pressure, like 130/80. And it was exactly that group. And the study team, I know they're Harvard, I'm saying his last name wrong, but they showed a reduction in blood pressure. So they just targeted that group, and that was ideal. I haven't seen as much on pre-diabetes. I haven't seen. And here's probably why. Because those clinical impacts and changes are going to be really small. And
or you'd have to follow for a really long time.
And like you just don't have the money and time for that.
Yeah.
Yeah.
So let's just be idealistic.
Sure.
What do you think, if you could just redesign how we provided healthcare and could do whatever you wanted in implementing Food as Medicine, what would that look like?
Yeah, so I am partial to our hub model. I really like that. So what that looks like is you have any healthcare provider across the state, and they, in a sense, they have their list, like the nurse does, and they say, okay, here we know it's type 2 diabetes, high blood. They know that list, if you will. And then all they have to do, and this is a perfect world. So in your electronic medical record, this is my perfect world, in the electronic medical record. So it's an Epic, it's called Epic Care Link, right? But all you would do, you hit this, send. That's it. That's all you have to do. So the patient comes in and they meet whatever criteria, like the state has agreed, insurance has agreed, all these, whatever the criteria is, and they just go, click. That's it. Okay. And then that patient name comes into our hub automatically, like it's an automatic transfer. And since we've met all HIPAA legal compliance issues, we get that name. That patient gets an automatic text message that day that says, you're eligible for a free Food as Medicine program, and they don't have to fill out paperwork. Okay.
Yeah.
So they don't have to fill out paperwork. All they have to do is opt in or opt out. And just by clicking 1 for yes and 2 for no. And if they click 1 yes, then one of our coordinators calls and says, and takes them through the screening tool and says, which program would be best for you? And then, as we've mentioned, that program is for 6 months. It's not for 3. It's for 6 months because that's where we see the biggest benefit. And the program's tailored to what they want. So example would be, oh, you want grocery prescription card and then the farmer's market voucher. Or you want the produce prescription box. Like you want to cook and you just need more fruits and vegetables. That's it. That's all you need. So just depending on what you need and where you live. And then of those programs, 50% are local. So now the farmer impact is huge. Mm-hmm. So you have more farmers than in that space, right? So they're having increased revenues and or you have more farmers coming into that space. So either increased revenue for existing farmers or new farmers coming in or both. And then you see this huge change in clinical outcomes, right? That's ultimately what we want. And so, for example, because again, I'm reading the Maha Elevate, Kentucky ranks, we're the bottom third for Medicare outcomes, like hospitalization, ED visits, stroke. We are the only Mississippi and Louisiana are better than us. So anything would be better. Like we have to, anything would be better. Like we
got a lot of room for growth.
Yes. So anyway, so that's really what we would love to see.
I like to
I can
dream.
picture it. Yeah.
Dream what it could be like in future years. But yeah, decreasing paperwork is always going to be helpful.
Yes.
And if you just had something to say to someone in general listening that maybe doesn't put a whole lot of stock in food as medicine, what would you say to them just to get started in thinking about that as part of their health?
Yeah, I think there's so many aspects. So I really can appreciate when someone says, I'm working 2 jobs right now, the last thing. I really can appreciate that it might not be at the forefront for that individual because they have enough going on. And it might be actually through stress that you then come around through food. And so sometimes I think that is almost like the first line is managing that stress and then saying, okay, because you're stressed, and you might be stressed financially, you might be stressed time-wise, both. And then it's easy to go for what's cheap and fast. And I completely understand that. So I would ask them first to just look at their stress and look at their stress response. And then say, this food is medicine program actually relieves financial stress. So that's the one thing we asked folks, what did that do to your budget? And so many people said they were able to buy like shampoo and soap. They were able to buy extra toilet paper. So what they did with that extra money, right, because they had $100 that didn't have to go to their grocery bill, they were able to buy more like life essentials. And then some people bought extra healthy food. And like one mom, we did this program with U of L, and it was moms, caregivers with their children. And one caregiver said, I bought vegetables I never have tried because now I had freedom to do that. Yeah. Just that $100 really can move the needle on that. But she chose it. It wasn't shoved at her. Right. She chose what vegetables she wanted to try. Do you see, when they're not thinking about food, I actually understand that. And I would start with stress and then say, through this, I'm going to help you reduce your stress, your financial stress, your time stress. And so then it frees you up.
Oh, that's very powerful. Because that's usually one of the most common obstacles that people state.
Yeah.
To keep them from doing it. They would love to, but they're like, where's the time?
And if someone's listening and wondering if they qualify for something and haven't automatically been screened, what can they do?
Yeah, they can talk to their healthcare provider first, and then second, they can go to our website, or they can just Google. Honestly, they could talk into their phone now with AI. They could just say, Food is Health, UK Healthcare, and then all of our information will pop up.
That's great.
Yeah. And tell us about what educational items that are available on your website for anyone to look at.
So there's over 40 different videos, cooking videos with nurse practitioners, registered dietitians, doctors, just really talking through how to prepare food and then the connection to that diet. We have ones for moms and kids. We have Alzheimer's on there. We have everything. Tons of handouts as well. And then actual recipe cards that they can download or just look at. And then they can put on their phone when they're cooking to watch on the screen as well.
No, that's great. Free resources are always good to have.
We'll have links to those in the show notes. And Sarah and I looked at several of the videos, and they're really good.
Yeah.
And the recipes look good, too.
Yeah.
Thank you so much. This has been really eye-opening because it's something that I know Sarah and I dream about, this being a part of healthcare, but we haven't really gotten to have our hands on it or see it in action. So it's exciting to hear the results you're getting and just the patients wanting to be involved and complete these programs.
Yes, I know. I am so excited to hear that it's happening, it's continuing, it's going well, and we can only dream of the future and how this can look now.
Yeah. All right. We'll see you next time.